and I hate that. And now, of course, the natology vision that you are teaching is more accessible for everyone. Actually, we
For
can,
everybody.
yes, it's easy to understand. The examples, the garage, the car, it's easy for everyone.
Yes, and I'm telling you, still is, I mean, when I'm treating the patient, I tell myself, thank God I have a protocol, because all of these are little tricks that you can use to uh, to understand the patient. I go back and I say, how is possible that I did not understand? I was treating patient with no clue, no clue, and so now with the gum, with this awareness of the horizontal and the vertical, so I myself, I am learning, because in fact, every time I give a presentation, I completely mess up the presentation. So I have to, for the next group, I have to go back and already redo, and there is no one presentation equal to the other. This is a
But
mess.
it's
I, I
it's it's quite funny because it's a personal opinion actually. Dentistry is cycle. Last 20 years ago, it was all function, bruxism, bruxism, bruxism. Now 10 years erosion, and now we're going back to function again. It's
But
crazy.
we if we don't know the physiology, we cannot define the pathology. So that's when I say these people are horizontal chewer. For me, if you put a wall, you create a bruxer, but they are just horizontal chewer. So this is why in my new classification that they will never publish, but anyway, I'm writing the book, and it will be published, I hope, at the beginning of next year, because I finish writing all of them. And so in that book, I publish whatever I want. And this classification is excellent, because it's really so good about function. And because the function is something that I have learned in the past 6 years. Before it was just phase two. Now it's phase three, and I introduced the vertebra. And actually, it's amazing, because people that were talking about the vertebra, they were not talking about the teeth. So the dentist was like, what? I'm lost. I cannot touch the patient. Instead, I say, you absolutely have to touch the patient, but do it with the test drive that you can come back.
Of course.
Okay, guys, let's go, because I need to explain to you the picture, because next time you are supposed to bring your own case, one case of yours. So you remember that in the first exam, you are supposed to do a clinical exam. I do a clinical exam for function, radiograph, but photograph and video, I do myself. I don't have an assistant that does, because I do diagnosis through the photo. If I ask an assistant, they will never capture what I want to capture. So I have a list of specific picture, always the same. And if I have something that doesn't fit in my potential diagnosis, I switch and I add more photo. This picture that was, and that you see everywhere, I love it, but I don't have time to take this picture, because I have 10 minutes to photograph. And so I don't even have the bouncer, the umbrella. This picture are taken while the patient is sitting on the chair. We don't even have the time to make him stand up. And there is my assistant with the little towel, black, that goes behind the chair. And so this is the black background, very fast. But what I don't want to do a shooting of the patient. I don't care. Remember which are my parameters. I want this picture because in this picture, I have together the eyes of the patient and the mouth. But this picture should be taken correctly because we need to zoom the picture and still be on focus. Do I care about the vertical harmony of the face, of the nose, of the philtrum? I don't care about that. What I really care is, like I told you, my teeth, because there where the patient notice the central axis and the contact point by the two central. This is the vertical that I want to see. So is the central axis what I don't have to mess up. The second type of harmony is the horizontal. Do I care about all of this? I care in a reasonable way. It means that there are people that have an eyes different from the other. I'm not going to stress the patient with this perfect symmetry. Just I want to know if the maxi line in the eyes of the patient is straight, oblique, or step. That's what I want to know. Because after that, I have to decide where to position. And this should be taken with the zooming. So this picture should have the lips slightly open because I need to see this maxi line. And I need to see the harmony of the corridor. So the posterior teeth. So people that smile like this, not interesting. They have to expose this angle. They should open up of the in the smile. And it's always the same. What I want is the maxi line. That's what I want to put together. This maxi line is my important reference, and it would be association to the other lines, the three superior lines. And these lines are called the aesthetic plane. They are fabric, they are made of the external cusp of the maxillary posterior teeth. So this is when you see this patient smiling, you are looking at the three superior line. What is the best way is really to start to remove unnecessary details. So I remove the lips because I want to see really this maxillary, how is related to the eyes. So I come with the camera as close as possible. Do I need this? No. If this is in the picture, do I need? No, I want to come even closer. And that is the shot, the picture that I take to be really sure that I use the bottom of my camera to make like the frame to see all the maxi line, and the other upper part of the box are the bipupillary line. So I just go closer with the camera and I aim for the pupillary in the upper, and I know that this one will be on focus. So this picture is very important to really understand in the frontal view how is the patient. This is called maxi stretch. Stretch because I put the retraction cheek and I just want to see the bipupillary line and the maxi line. These are the picture of the three step where you see the parameter and here how should look like the picture. All the smiling picture, I'm not interested too much I don't do a ha ha ha, but I need absolutely to put, to give to the lab technician a frame of lip. And many people don't smile, they hide their smile. So many times when I ask for a smile, I have to make a sound. So I say, "ee," and I keep saying that because when you say "ee," this upper lip goes up. It goes up. And so allowed me to do what? To look at the gingiva. Do I care a lot about the gingiva? Not so much like other people. Because if my patient don't ask, I don't go to do crown lengthening because I'm so into preservation of the supportive tissue that sometimes I see crown lengthening even in the posterior for the to get the harmony with the exposed roots. So I stopped to this madness. I do very minimal crown lengthening, like I was explained to you, with the little flow, X-ray. If the level of the enamel is higher, I do myself a little surgery. That's it. That's the maximum. The rest, I try not to push the patient for this major crown lengthening. This is the gingiva. I want to see if there is harmony of the gingiva. After that, all the rest of my attention is concentrate on this area, the maxilline, the aesthetic plane. To do so, the mouth should be open very little, but this is way too little because here I don't see the maxilline. I need a minimal opening so the maxilline would be with the black background possible because it's better in evidence. And at the same time, if the patient smile little, the U shape is more harmonious. If your patient smiles too fast, too big, the U shape, it's too like a V shape. So when you have the patient smiling, you need to have not such a big opening because in this way, the lips will not be a V shape. What I don't like here is that this does not go sufficiently up because I can see the maxilline, but I don't see the aesthetic plane. And that's why to get the lip position and enough vision, talking about the white